Great. Thank you, Esmeralda. And thank you everyone for coming today to our first seminar of winter quarter. It is truly my great pleasure to introduce today's speaker, Noreen Goldman. Noreen is the Hughes-Rogers Professor of Demography and Public Affairs at Princeton University, where she's also a faculty associate at the Office of Population Research at Princeton University. She's published more than 200 papers, many on the impact of social and economic factors on health. She's designed several large-scale surveys in Latin America and Asia, and her current research focuses on racial and ethnic disparities in health in the United States. Noreen has far too many accolades for me to run through here, or she'd have no time for her talk, so I will keep this brief and just hit a few highlights. She served as a member of the board of directors of the Guttmacher Institute. She's been a member of the scientific advisory board of the Max Planck Institute for Demographic Research, a fellow at the Center for Advanced Study in the Behavioral Sciences and at the Russell Sage Foundation. She served as vice president of the Population Association of America and has been a member of numerous committees of the Institutes of Medicine, the National Academy of Sciences, and the National Institutes of Health. And she's served on multiple editorial boards. More recently, many of you, in addition to knowing her from her research and wide professional accomplishments, may remember her as a visiting scholar here at UCLA. She visited us in 2005 to 6 and again in 2014 to 15. So I guess in addition to saying welcome to Noreen, I should be saying welcome back to CCPR. Before we begin, I just want to say that it would be helpful if folks could ask clarifying questions during the talk, but save your questions of substance for the Q&A to make sure that she can get through her presentation. And with no further ado, please join me in welcoming Dr. Noreen Goldman. Take it away.
Thank you. Thank you for that lovely introduction. And thank you, all of you familiar friends and colleagues for attending and for inviting me. It's just frustrating not to be able to be there in person, not just for the food that I love, but for seeing all of you. Hopefully that will happen soon. So let me introduce today's talk, which is a compendium of a few papers published this past year and a couple that are in progress now. And I very much welcome your feedback. So the title is The Impact of COVID on Life Expectancy in the US and Brazil, Disparities and Dependencies. And I should mention that much of this is based on collaborative work, especially with Teresa Andresfay, who's now at USC and is on this call. And I'll be really happy to direct your questions to her when the time comes. Also with Ann Pedley and many other people have been involved in different parts of this work. I'm assuming you can see my slides okay? If not, yeah, somebody shout. Okay, so the first part is on disparities, particularly disparities on the impact of COVID on life expectancy and the focus on racial and ethnic disparities. Okay, so just to really summarize what this impact has been, I don't know why. The cumulative number of deaths from COVID as of the end of 2021, just a week or two ago, has been over 800,000 deaths in the US due to COVID and over 600,000 deaths in Brazil due to COVID. And you can see in terms of death rates, Brazil is actually a little bit higher. It's a smaller population than the US. But these are the two largest confirmed number of deaths in the world due to COVID and among the highest rates in the world. And I can show you that the rates in the next slide from the Johns Hopkins website. You can see with the little arrows that both Brazil and the US are among the top death rates in the world. The only countries that exceed them, at least according to the recorded data and our extent of belief in these data, are some countries in Eastern Europe. All right, so we are dealing with countries with extremely high COVID death rates. Why these two? Well, these two are done because I live in the US and I have a lot of colleagues in Brazil is the choice of these countries. But they do have things in common. Most obviously, Brazil still has, the US had a narcissistic leader through much of the early stages of the pandemic who was scornful of the virus, of science, of health in general, healthcare. There was poor coordination at a national level in both countries. Both countries suffer from huge structural racial inequalities, huge political divisions across states and subunits. But there are some important differences, one of which will be relevant to some material later, which is the vaccination rates. Brazil was very late in coming to getting effective vaccines, in part because of Bolsonaro. But once it got it, it caught up and has surpassed, as of November in 2021, the proportion who were, quote, fully vaccinated, which meant 2 doses, exceeded the US even with the very late start. And one big difference that this reflects is the trust of the population in the healthcare system, in public health, in responding to crises, and a long history of vaccination and accepting vaccines, even if it means, or perhaps because it means, not listening at all to their leader. Okay. So let me move now to talk about the US, which I'll talk about actually quite a bit more than Brazil. So what I'm showing you here is a recap of work that Teresa and I published originally in PNAS in the beginning of 2021 and updated a couple of months later in the JAMA network, that asks the question of what has the impact been of COVID on life expectancy at birth? And we compare the years 2020 to 2018. Believe it or not, 2019 data by race and ethnicity are still not available from NCHS, but the difference would be minute. Life expectancy at birth went up by 1/10 of a year between 2018 and 2019, the 2 pre-pandemic years. So the difference would be trivial were we to update this. So what you can see from this graph is, pretty steady rises in life expectancy from 1980 onward, some stagnation prior to the pandemic. These are phenomenon very well known. The Latino paradox, the fact that Latinos have higher life expectancy than whites, which has been well studied by demographers. And what this graph points to is the drastic decline in the 1 year 2020 from pre-pandemic, a decline that was on the order of 3 years for Latinos, almost wiping out whatever advantage that had been accrued prior to that. A decline of almost 1 year for whites, 1.3 years overall for the population, and almost 2 years for the Black population. And let me mention at this point that although a lot of these papers look at life expectancy at birth and life expectancy at age 65, for this talk, I'll focus on life expectancy at birth, just trying not to cover too much ground or talk too fast. Okay. So what about 2021? Okay, so these are very recent data, and thank you again, Teresa, for being willing to update this at the very last minute. So what we start here is showing the age distribution of COVID deaths by the same race and ethnic groups, whites, Blacks, and Latinos, but in both years, 2020 and 2021. So this is just numbers of deaths by age. So you can see a couple of things. One is the mean age of COVID deaths declined among all groups between 2020 and 2021. Not surprising in that the decline was highest at the oldest ages, partly due to coming to grips with the very high rates of institutional nursing home deaths, and because older people were offered the vaccine and took it up before other age groups. So we have a decline. That decline occurred uniformly, although at different degrees for the different ethnic groups. But what's also interesting is both the Black and Latino population had younger average ages of deaths for COVID than the white population, both in 2020 and 2021, which is partly because they are younger populations, but more because the death rates were proportionately higher for those two groups at younger ages. Okay, so what about death rates? These are distributions of deaths, and we know as demographers, we're not supposed to look at numerators alone. So what happens if we look at death rates? So these are COVID death rates by age group, the age groups that are published, not always the ideal age groups, the Black population and the Latino population relative to the white. So all of these rates have been divided age group by age group compared to the white population. Okay, and I show this because one of the questions that drove this update in 2021 One was the hope and the expectation that the impact on life expectancy would not be as dramatic as it was in 2020. The second was that the disparities would be smaller, that you wouldn't see these exceedingly large disparities due to COVID from the Black and Latino populations. And let me just say that these estimates, which I'll describe how they came about in a little while, but they're COVID specific. They're not the total impact on life expectancy. They're life expectancy due explicitly to COVID. And in fact, the Black population had greater losses due to non-COVID deaths that put it more on a par with the Latino population. Okay, so, but looking at age-specific death rates from COVID relative to whites, 2020 and 2021, we can see what looks like a huge decline in relative death rates. In 2020, both groups had death rates 4 to 5 times as high as whites. By 2021, still huge disparities, but disparities on the order of between 2 and 3 times rather than 4 and 5 times the rates for whites. Okay, so does this mean that the racial disparities in the decline in life expectancy declined between 2020 and 2021, as this might lead us to believe? The answer is, well, sort of, not really. It's a pretty wishy-washy answer. So what is the story? So this graph shows you the declines in life expectancy at birth due to COVID by race and ethnicity, both for 2020 and for 2021, both estimated through these multiple decrement procedures that I'll describe shortly. The estimates are slightly different than what I showed you a few slides ago because COVID deaths keep getting updated. So this was done recently. It's a 0.1 of a year different from what we published about a year ago. But you can see, again, the largest decline for the Latino population on the order of 3 years, but both in 2020 and again in 2021. Green for 2020, blue for 21. Similarly for the Black population, pretty much the same in the 2 years. For the white population, the impact in 2021 was substantially greater than 2020. Okay, and hence, because the majority of the population is white, overall, when you average across groups, the impact in 2021 has been greater than in 2020. Counter to our prediction when we published the early papers, expecting that availability of vaccine would have not eliminated this, but led to a smaller impact of COVID in this past year. Have the disparities declined? Well, in relative to, or absolute terms, they have. They have only because the white population did worse, not because either the Black or the Latino population had a better outcome in 2021 than 2020. Okay, so that's rather a depressing story. So the Latino story is one I focused a little bit more on, partly because my previous research had looked at Latino health, and partly because in some sense, it's surprising that a group that had experienced on the order of almost 3.5-year advantage in life expectancy relative to whites from when we first recorded these data a little after 2000 until 2019, had such a huge impact, right? We know about comorbidities, and in some sense, one might have thought comorbidities would have protected this population being healthier on average, although not in all respects, than the white population. So it reminded me a bit of a paper I published in 2015, which was called, Will the Latino Mortality Advantage Endure? All right, so this is clearly several years before COVID surfaced. The Latino advantage had continued year after year. I argued that probably it would decline in the coming years, although it was not willing to make a prediction as to when, because despite having higher life expectancy, Latinos had higher rates of obesity and diabetes, higher rates than whites, and increasing rates. They had higher rates of disability, and the stresses of being an immigrant, particularly an undocumented immigrant, of not just the border crossing or the multiple border crossings, but life once immigrants arrived here was likely to have some impact on chronic disease. Okay, clearly I didn't predict that an infectious disease would begin to close the gap, but in truth, there was no reduction as of 2019. In fact, the advantage of Latinos grew somewhat, in part because whites were doing poorer, partly heart disease, partly overdoses. But in 2020, as you saw from those graphs, the advantage was almost eliminated despite their pre-2020 health advantages, and 2021 is more or less the same story. Let me avoid any confusion. I think I mentioned it on the slide, but didn't say it out loud, that each one of these declines, 2020 and 2021, is relative to pre-pandemic. In this case, 2018, it will be updated to 2019. It's not 2021 relative to 2020. So each year saw pretty much the same decline relative to what it was prior to the pandemic. Okay, so why this huge impact for Latinos? Here's a slightly arbitrary division into risk factors that imply higher exposure to COVID versus those that imply higher mortality for those infected. And you can see there's quite a list of risk factors. One is Latinos are heavily involved in what are called frontline occupations. I'll show you some numbers in a minute. Occupations that cannot be done by and large remotely or from home. This is particularly true for Latinos working in the informal or gig economy in jobs with very low pay. It's also true that Latinos had the highest rates of job loss of any of the groups because of these industries having closed down early in the pandemic. Whether job loss means you're less exposed or not or more exposed is a little bit of a confusion. You lose the exposure due to the job, but you also suffer tremendously financially and food insecurity, potentially access to healthcare. Latinos are more reliant on public transport than many groups. Among all ethnic groups that we've looked at, they have the highest prevalence of multi-generational households, also crowded households. Clearly, an infectious disease spreads quite easily in those kinds of settings. Many face language barriers. Information in Spanish was not always as available as information in English regarding both how this disease spread and how to protect themselves from the spread. Higher mortality for those infected. I mentioned that Latinos had higher rates of diabetes and obesity. Now they have lower rates of cancer and heart disease compared to whites, but obesity and diabetes were two conditions that were definitely comorbidities that increase the probability of both getting COVID and suffering, having a more serious disease or requiring hospitalization from COVID. They have lower access to healthcare than other groups, especially the undocumented. They're not entitled to some of the benefits that other groups received during the pandemic. Their providers have lower resources, and on average, they're provided with lower quality of care. Okay, so this table that comes from a paper that was joint with Ann Pebley and Kumbak Lee, who had been a postdoc at UCLA, and Teresa, who was on the call, Pratt at Princeton, shows the proportion of different ethnic groups, of some of the ethnic groups that we looked at in frontline occupations, meaning, again, that these were occupations that typically could not be done at home. And what stands out is that Latinos have the highest proportion of workers in frontline occupations of all the groups. Okay, a lot of these are in construction, leisure, hospitality, some meatpacking industries, and often the informal gig economy. What's also interesting, but I haven't really done much looking into this, is that there's quite a large sex difference in proportion in frontline work, unlike many of the other ethnic groups. It's also the case that Latinos experience the largest sex difference in the decline in life expectancy. I haven't broken my numbers down in this talk for men and women, but in the data that NCHS produced, men had much, much higher impact of loss of life from COVID than did women, which could be partly related to this very large sex difference in being a frontline worker, which was also experienced by the Black population. Okay, so now I'm going to show you a pretty complicated slide and do my best to communicate it in not a huge number of words. So what we tried to do in this paper is look at representation of a dozen different ethnic groups. I'm not going to show you all of them, but I want to concentrate on the Latino population for a bit. Exposure to frontline jobs that were high risk meaning high risk of infection, of proximity to others, of being in jobs that involved a lot of face-to-face confrontation, jobs that were typically indoors, or jobs that involved external customers. We looked at these 5 risks. So how did we do this? So we looked at the American Community Survey in 2018. From that, we looked at people who worked over the last 5 years, most of whom were working in the year prior to the ACS. We identified 409 occupations. We looked at which of those were frontline, i.e. could not be performed typically remotely or from home, of which there were 249 of the 409 occupations. We linked data on these occupations with ONET, an external database from the Department of Labor that has lots of information on job characteristics, focusing on these 5 characteristics that I mentioned are most likely to be associated with the risk of transmission of an infectious disease. Okay, and we also used ONET to help us define what a frontline occupation is. What are the occupations that cannot be done in person? Okay, and then we further divided the occupations into quartiles of occupational standing. I should backtrack a bit and just say high risk means of all the occupations in this data set being in the highest quartile of ranking of exposure to infection, proximity, face-to-face, et cetera. Then we divided these occupations into quartiles of occupational standing, where occupational standing is based on all the workers in the ACS in an occupation, looking at what proportion had at least some college education. Okay, and you can see these data are broken into, I have to get your faces out of my image, into 4 quartiles of occupational standing. Okay, so why have I tortured you with all of this? Okay, so the idea is looking at representation in high-risk jobs, frontline jobs relative to all frontline jobs. And overrepresentation are in these orange colors, underrepresentation of high-risk frontline jobs compared to frontline jobs are green. If you look, for example, at white males, and separately for each of these 5 risks, you can see whites are light orange, overrepresented in the 4th quartile, the highest occupational standing based on education. Whites are somewhat underrepresented in the 1st quartile. Okay, that picture changes dramatically when you look at the Black and Latino population, right? So the Black and Latino population, looking momentarily just at the males, vastly underrepresented in 4th quartile jobs, overrepresented in 1st quartile jobs, 1st quartile of occupational standing. What are these kinds of jobs? So the most common frontline jobs, that's not the way I wanted to go. Okay, the most common jobs in the highest quartile are registered nurses, physicians, surgeons, all jobs clearly high risk of infection and proximity to others indoors, et cetera. The most common jobs in the 1st quartile, the lowest educational standing quartile, are cashiers, drivers, janitors, laborers, store clerks, housekeeping cleaners, sometimes also involving health aides. Okay, so why did we do this? We did this because our feeling was that these occupational standing quartiles were very correlated with the kind of mitigation strategies or protection workers could get. Workers in the 1st quartile are those who are least likely to have provided themselves or employers to have provided protections, be that mask, social distancing, improved ventilation, et cetera. Workers in the 4th quartile, while doctors and surgeons are clearly highly exposed to infection, they also, as soon as it was possible, had access to protective equipment, and the workplace had undertaken measures to protect them. So this is just to point out the ways in which Latinos were, as frontline workers, were also exposed to high risks of infection. So let me just contrast that very briefly with another subgroup. looking at Filipinos in particular, and Filipinos and Chinese, okay? Also extremely high risk of being high representation in high-risk jobs relative to their representation as frontline workers. Huge, but these overrepresentation numbers are all in the fourth quartile. Okay, most for Filipino men and women, this is largely registered nurses, as well as for Chinese women. For Chinese men, the highest status frontline occupations are typically physicians, surgeons, dentists, pharmacists, and registered nurses. In contrast, they're typically underrepresented in the lowest occupational standing jobs. So in huge contrast to the Black and the Latino populations, the Chinese, the Filipino, in this case, the Vietnamese males are also in high-risk occupations, but in a very different level of occupational standing, and hence very different likelihood of being able to have access to or use of risk mitigation strategies. Okay. I hope that went over okay. Okay, so let me say a few words about the Native American population, American Indian and Alaskan Native. Okay, there was a lot of media attention early in the pandemic. It seems to have died off in 2021, but certainly a lot in 2020 about how the parts of the US with the highest rates of COVID were all on Indian reservations. Anyone who's worked on the Native American population will know how difficult it is to get the kinds of data that you want to look at this. The COVID deaths were broken down by Native American in addition to Latino and Black. And what we looked at were initially the crude death rates from COVID, age standardized. These are indirectly standardized, standard mortality ratios, because we could not do age in place. We did not have data by age and ethnicity, also by county. So we did indirect standardization. But the main point here is, although it looks like Native Americans have slightly higher crude death rates relative to whites from COVID compared to Latinos and Blacks, once you standardize, you can see a non-trivial difference. Regardless, you can see that among these groups, Native Americans have the highest COVID death rate of the various groups. Okay, so why? It's a question we asked. It's not one we did a terrific job of answering, and partly because we were interested in the role of reservation lands, but you don't have that data on the death certificate. You don't know where a given person has lived or with. So what we did is an aggregate analysis, and we looked at the 16 states that have the highest proportion of Native American residents. These 16 states account for a little over 3/4 of the Native American population in the US. And we looked at these standardized mortality ratios. And we correlated the percent of Native Americans who live on a reservation with the mortality ratio. Standard mortality ratio is not an ideal measure, but you can see a pretty strong correlation. And that correlation was there if we did just direct standardization by age, or if we did indirect standardization by age in place. Okay, it's not perfect, but it does suggest that living on a reservation was a risk factor for dying from COVID. Okay. And what we then tried to do is to see what factors lead to that risk. And so we had information from the American Community Survey, as well as the risk factor social survey, the BRFSS, that gave us these are some of the measures we were able to get by ethnicity, specifically for Native Americans in each of these 16 states. Okay. And you can see, you can't quite disentangle these, and I was quite reluctant to think of a regression analysis of all of these pretty highly correlated covariates. But the mortality ratio was inversely related to the income poverty ratio, was positively related to the proportion of households that had at least 3 generations in them, very similarly to the percent of households that were crowded, measured by a standard index of crowding, negatively related to health insurance, excluding the Indian Health Service, which was automatically given to people on reservations or nearby lands, but was well known to be very inadequately funded and had very limited services. So although most people on reservation had access to it, the percent who had health insurance beyond that varied dramatically with the COVID rate. The percent who were frontline workers positively correlated with the COVID death rate. Percent who had diabetes, likewise, I'm not showing it because I can't squeeze it on this one slide. The percent obese also highly correlated with the COVID rate, and the obesity and the diabetes rates for the Native American population exceed those in all of the other populations that we have looked at. True for actually many of the chronic diseases. So at the point we did this, it was published only a month or two ago. There had never been a life table for Native Americans in this country, which is why we resorted to this way of doing things. However, NCHS published one this past November for the first time for 2019. Okay, that allowed us, and thank you again, Teresa, for doing this, to try to get the same metrics as we had gotten for the Black and Latino population for 2020 and 21. In this case, we had a 2019 life table for Native Americans. I should mention that, part of the reluctance to develop this life table, it wasn't just stubbornness on the part of NCHS, but race reporting is very problematic among the Native American population. So there's a non-trivial proportion that report multiple races, and that proportion differs substantially on surveys or a census from what happens on a death certificate. So Native American race reporting on death certificates is substantially underreported. So that if you try to calculate deaths from death rates without adjusting death data, there's a vast underreporting of deaths, which is probably the case also for our COVID data. Okay, a lot of the data I showed you from the ACS and the BRFSS are single only Native American reporting, although we also looked at multiple race reporting, and not surprisingly, multiple race reporting has rates lower than the single race Native American reporting, but also substantially higher than whites. Okay, so NCHS adjusted their life tables based on some matching surveys that gave them a clue of the underreporting of Native American race on death certificates. Okay, so now looking at this graph, these are COVID death rates relative to whites. It's the same graph that I showed you a number of slides ago for the Black and Latino population, now with the Native American population added to this. Okay. And there are a couple of things that are really surprising to me. One is I would have expected the 2021 death rates to be far below the 2020, partly because the Native American population was very receptive to vaccine uptake, in contrast to the Black and Latino populations, where there was a long delay until rates started to approach those for whites. And then you had white hesitancy that made them more equal, and undoubtedly part of the large impact of 2021 COVID deaths for whites. The other thing that this shows is that COVID age-specific death rates for Native Americans are actually slightly higher than for Latinos. And we know the dramatic impact that we saw for Latinos, not at all ages, but particularly in these young, middle-age, young adulthood and later adulthood ages. The rates are extremely high as 5 to 6 times that for whites. Okay, so if somebody should shout if I'm going too quickly, because I know I'm going through a lot of material, and since I can only see one of you and I'm saying no, it's not too quickly, I will proceed at my normal rate. So the rest of you will have to shout because I can't see all the faces and see my slides. Okay, so moving to what is the impact of life expectancy now for Native Americans relative to Latinos and Blacks. And this is the result. Okay, So you can see the decline in life expectancy at birth in both years, 2020 and 2021, is huge, but not quite as huge as Latinos, which kind of surprised me a little bit, given that age-specific death rates from COVID were a little bit higher. So this kind of threw me back in the last couple of days to think about elementary demography. And I think what the story is, apart from issues of any misreporting, which I'm sure are quite prevalent here, is that if you look at pre-pandemic life tables, and I've given you some clue on the right. So before the pandemic, which in this case was probably 2018 data, Latinos had a life expectancy of about 82 years, Native Americans, which I've put NA, 72 years. 10-year gap in life expectancy. I mean, that's pretty mind-boggling for non-trivial size groups in the United States. In 2021, the gap is still about 10 years because both groups had, declines of about 3 years in 2021 relative to pre-pandemic, okay? But the death rates pre-pandemic were extremely high for Native Americans in youth, the sort of young adults and middle ages, sometimes more than 5 times as high as Latinos, right? So these are death rates. Now, some of them are low death rates, so getting ratios 5 times as high may not be still an astronomical rate, but these are deaths due to homicide, often liver disease due to alcoholism. And so the impact of COVID in terms of life expectancy might not be as great as you would expect, given that there were high rates of dying from other diseases in the Native American population in those ages. Okay, so there's not a direct translation into relative age-specific death rates and decline in life expectancy. That's just sort of a demographic aside. But apart from that, we are talking about a huge decline for a population that already had a life expectancy far lower than you would see in most middle-income countries, and has now fallen below 70 years. I mean, that just shouldn't be in a modern, I was going to say democratic country, but maybe I shouldn't say that. Okay. So a few words about Brazil. I'll say less about Brazil until this methodological point that I'll raise. So this is a paper published with Marcia Castro and colleagues the early part of the year that looked at decline in life expectancy at birth and also at age 65. As for the US, this graph happens to show both because it's color-coded in both directions. This compares 2019 to 2020. In this case, we were able to compare the US and Brazil for 2019 to 2020 because it wasn't done by race and ethnicity. So we had 2019 life tables. Brazil in 2020 had a slightly smaller decline in life expectancy at birth than the US. But as you can see, huge disparities, okay? Some states in the North had setbacks as great as 20 years, kind of equivalent to what we were seeing for the Black population in the US, particularly in the North. Amazonas had a huge decline. It's also the state with the highest poverty level in Brazil and low availability of hospitals and physicians. Okay, the colors on the right here, the aqua and the purple, are the highest declines in life expectancy at birth. So we would like to have done this also by ethnicity. The problem is there are inconsistent reports, as I mentioned, for the Native American population in the US, of ethnicity between death certificate data and population data, which made our colleagues reluctant to even go that route of looking at ethnic racial disparities in Brazil. This is a graph I've taken from a published paper just to show that that map of loss of life expectancy in 2020 maps very closely with socioeconomic inequalities here. These are color-coded according to measures of social vulnerability, which are based on employment and housing, income, and education. So these COVID death rates largely mirror social disparities. This is 2020. Most of what we did was 2020. We did look at the time we published the paper at the first 4 months of 2021 in Brazil, and the number of deaths exceeded all of 2020. Brazil, as you may recall, was quite late in getting access to vaccines. It wasn't helped by any messaging from its president or governors of some states that supported the president. In 2021, there are twice as many COVID deaths as in 2020. The calculations for the impact on life expectancy are in progress. There was some hacking of the websites in Brazil that delayed this. But the disparities, the state and regional disparities, largely show the same pattern in 2021 as they did in 2020. Okay, so the remainder of the talk, I want to talk about ways that one could estimate the decline due to COVID. Okay, and we did this. This is in progress. Well, part of this is in the Brazil paper, and part of this for the US is in progress. The three different ways that we could estimate how much life expectancy at birth declined due to COVID between a pre-pandemic year and, in this case, 2020, but it would be the same story for 2021. Okay. The simplest way, and one we could do for Brazil, and we can do now for the US, but we couldn't at the time Teresa and I were writing our paper because the data were not available, is simply to take all the deaths for 2019, all the deaths for 2020, make each one into a life table, calculate life expectancy at birth for each of those 2 years, and take the difference. I call it life table for 2019 minus life table for 20. Get those differences in life expectancy at birth. It means that you have data for all causes, which again, the NCHS was pretty slow in releasing. And the difference, this metric reflects differences in all causes of death, not just COVID. It's whatever happened in 2020 that didn't happen in 2019. Some people call that excess deaths. The term excess deaths is a little ambiguous. Sometimes it just means compared to what might have been normal or pre-pandemic, and sometimes it means beyond COVID, what was the net impact from other causes? Okay. A second approach, and it's the one that Teresa and I used for our early papers when we didn't have all-cause mortality for 2020, was what I call DT19, a decrement life table approach. Okay, what it says is, assume that had we not had COVID, death rates would look just like they did in 2019, age group by age group, pre-pandemic, which was not absurd because 2018 and 2019, they're all pretty similar. Some years we went up 0.1 of a year in life expectancy, some years we went down. Then take the COVID deaths for 2020 and add them in an actuarial appropriate way using Cheng's method, get the new life table, get the new life expectancy, and compare with what it was in 2019 and do that difference. That's essentially what we did. It assumes independence. It assumes that had there been no COVID, death rates would have been as they were in 2019. And then there's a third approach that says, we call it the decrement life table approach for 2020, or DT 2020, which I call the common cause deletion, because going back decades and decades when I was a graduate student, it's kind of what the textbook said. It said, what would be the impact if the United States could eliminate cancer or could eliminate heart disease? And this is basically what they did. They said, you take the life table for a given year, in this case for 2020, you remove all the COVID deaths in a proper actuarial way, you calculate the new life expectancy, and you compare it with what we actually had for 2020. This also assumes independence of causes of death, that death rates in the absence of COVID would equal the death rates from all causes but COVID in 2020. Okay, so it's a different assumption, but it's also an assumption of independence. Okay, so we did all three methods for Brazil and all three methods for the United States. Okay, and so the big question is, is this good? Is this assumption of independence plausible? Is it plausible in either place? Is it ever plausible? Okay, and with some more knowledge that's been gained through all of this, I would say independence is probably a lousy assumption for COVID-19. Okay, why? What impact would COVID have on non-COVID death rates? Okay, well, death rates from non-COVID causes, what I call chronic diseases, okay, heart disease, cancer, stroke, could be going down in the presence of COVID because of harvesting, which is to say, we know there are a lot of comorbidities that increase the risk of dying from COVID, cancer, heart disease, especially cancer, one could argue, if people have a compromised immune system, serious cases of cancer that might have died in the next few months. If these people got COVID, they could die first from COVID. Okay, and that would bring the cancer rate down. In the absence of COVID, they might have died from cancer, but with a compromised immune system, they were very likely to succumb to COVID. Okay, but comorbidities could also increase the rates, right? So having COVID could make heart disease worse. We know it raised blood pressure in the United States, right? So it could lead to an increase in these other non-COVID causes. And we all know that as medical facilities shut down, delayed care, primary care, disease management, treatment, all of this care was reduced. It could increase rates from diabetes, heart disease, all non-COVID causes. People who recovered from COVID but had long COVID could also have, as the data suggest, increased risks of dying subsequent to recovery from COVID. And there's information suggesting COVID affects various organs like the lungs, the kidneys, and heart that could lead to that. Then health behaviors changed during the pandemic. Many people ate worse. I certainly ate better, a lot of great baked, high sugar, high fat goods. It reduced exercise for some people who couldn't go to gyms or weren't walking to work. It increased smoking. And in some cases, it increased drinking. It increased use of other substances. So rates of heart disease, for example, or other causes could have gone up. And then the enormous economic and social stresses could affect many of these causes, okay, via blood pressure or other routes. Okay, for external causes, it's hard to know. They could have gone down, they could have gone up. Traffic accidents in the early months went down as businesses shut down and people weren't driving and they're not taking vacations. Substance overdose in the US, we know, went up. And then there's miscoding of cause of death, which could either make these non-COVID death rates go up or down, depending on the direction. And this was especially likely before we had tests for the COVID virus. And we couldn't distinguish other respiratory diseases necessarily from COVID. And change in either the percent or the types of deaths that remain unclassified could have an effect on all of these non-COVID death rates. Okay, so my hypothesis, Teresa and my hypothesis, when we did this multiple decrement procedure initially, was that non-COVID death rates increased during the pandemic. So these decrement methods will underestimate the overall change in life expectancy at birth because there will be an increase in non-COVID deaths that make the decline greater than what we are able to estimate. And many folks in the US anticipated a large underestimate. Okay, so given all of this that I've listed, you might say, like, why are we bothering with decrement approaches altogether? Well, one issue is the US is very slow to produce life tables. It used to take it several years. It's slow to reduce deaths from all causes. Other countries are even slower. Okay, so if you want to make an estimate or see an impact, for example, we wanted to by race and ethnicity, they still haven't released the 2020 data. They still haven't released 2019 life tables by race and ethnicity. Also because doing the direct calculation of the difference in life expectancy between two full life tables may reflect more than COVID, right? Not all excess deaths in 2020 or 2021 could be attributed to COVID. Opioid deaths are the clearest example where the rates of opioid deaths were going up in the months preceding the start of the epidemic in early 2020, partly because of fentanyl and other synthetic opioids, which were more deadly. Okay. And third, I would say, some people might be interested in the direct COVID impact. Having said that, I'm not quite sure how we actually get that, but because it will always be tainted by the kinds of things that I mentioned. So here's the $1 million question. Does it matter much which method we use to estimate the decline in life expectancy at birth for Brazil and the United States? And here is the answer. So these are the estimated declines between 2019 and 2020 in Brazil and the US in life expectancy at birth, according to these two methods that assume independence of causes. One assuming in the absence of COVID, death rates would have looked like they did in 2019. The other assuming that in the absence of COVID, death rates would look like what they did in 2020 for deaths other than COVID. And this is the difference in life expectancy based on having the entire life tables. So just looking at differences across all causes of death. Okay. So the answer is, yeah, it seems to make a difference in a very surprising way. And I put an asterisk on this 1.6, which is what we estimated. But a paper was released only 2 weeks ago suggesting that the earlier NCHS estimates, which were closer to 1.5, are now 1.8. They have raised their estimate of the decline in 2020. They haven't explained why. They haven't shown anything by race and ethnicity, but we can see from the number of deaths due to COVID and non-COVID that the difference is mostly non-COVID causes that maybe came in late to the data collection. What that means is that this will be closer to 1.8, and these other ones won't change much because the number of COVID deaths hasn't changed. So any way you cut it, the decrement approaches give a non-trivial underestimate of the overall decline in life expectancy in the US. And what's surprising is that it goes the other way around in Brazil. They give an overestimate. Okay. And these discrepancies, by the way, in the US vary a lot by race and ethnicity. The decrement approaches were pretty close for Latinos because Latinos, the vast majority of deaths that were higher in 2020 than 2019 were due to COVID. In the Black population, the decrement approaches did a much worse job because death rates increased for the Black population from many causes other than COVID. Okay, so this is all still work in progress. Okay, but let me try to give you some insights as to what's going on, which is exactly what my next slide says. What's going on? Okay, so why are the decrement approaches so far off from this simple change in life expectancy at birth? Which is to say, in other words, why is the assumption of independence between COVID and other causes not such a great assumption? Okay. And specifically, why do these decrement approaches overestimate the decline between 2019 and 2020 in Brazil and underestimate the decline in the US? That's really the puzzling one, because I would have expected everything going in the same direction. Okay, let's see to what extent I can answer it, although I'll warn you that I can't do a great job. Okay, so here is a way of looking at age-specific death rates, 2019, change in age-specific death rates between 2019 and 2020. These are percentage change, age group by age group, for men and women in the US and Brazil. This is all causes of death. Red are for women, blue are for male, and the total populations in yellow. So the main point here is that these percent changes are above the zero. They're positive. Death rates went up between 2019 and 2020 in almost all age groups except the very youngest in both countries. Okay, not a surprise, right? Because 2019 didn't have COVID, 2020 has COVID, and we would expect overall in both countries, the death rates would have gone up, although you can see not to the same degree. So that's a first clue. Okay. Now this graph, which looks pretty much the same, looks at the percentage change in age-specific death rates between 2019 and 2020. Same color coding, red for women, blue for men. But these are now death rates for all causes except COVID. Okay, and herein lies the answer, a partial answer, which is that deaths from causes other than COVID almost uniformly went up across the age range in the United States, more so at younger middle ages than at older ages in percentage terms. But in Brazil, many age groups actually saw a decline in death rates from causes other than COVID. Okay, now I should tell you, my colleagues in Brazil assure me, I mean, I trust them, but it's not the best way to verify data by believing in your friends, that deaths by this point, even much earlier, had been fully reported in 2020. it doesn't take care of a potential miscoding issue that I'll get into, but it's not a question of delayed reporting in total deaths for the year 2020 in Brazil. Okay. We also see, by the way, if the percent change in the blue bar is much higher than the red bar, particularly in the US, but in both countries, which is to say, and there's been a lot of publicity about this, that death rates, not only from COVID went up, were higher for men than women, but for non-COVID, the increase was much higher for men in blue than for women in red. Again, in both countries, but particularly in this young middle age range for the United States. Okay, so this approaches the question in a little bit more detail. These heat maps have a lot of information, so they're not easy to read. So what we did here is we took major causes of death, starting with all causes lumped together, then all causes except COVID lumped together, and then some big categories, and ending with those not classified, which you can see the unclassified in 2020 were more than twice as high in Brazil and the US, but they didn't change between 2019 and 2020 more than trivially. So that kind of helps us. They were always higher in Brazil than the US. But what we did here is we looked at the change between 2018 and 2019, the percentage change in age-specific death rates, starting with the age group 45 to 54, then did the same for Brazil in the US, 2018 to 2019, and then did it for 2019 to 2020. So it's looking at pre-COVID period for the two countries, then a COVID period for the two countries, looking at percent change in these 5 age groups, starting at age 45. Below that, the numbers are really small. So this reddish brown says the death rates increased. The blue says the death rates declined. Okay. And you can see all of these bars are divided with women on the left and men on the right. Okay, females, males. Okay, so let's start at the top. All-cause death rates barely changed between 2018 and 2019. This is practically white for Brazil and the US, which we expected. The life expectancy was pretty constant in those years, as were age-specific death rates. 2019 to 2020, everything is kind of this brownish red. Death rates increased across all of these age groups, 45 onward. Okay, that makes a lot of sense. All except COVID, death rates for all causes except COVID. Again, now you see a kind of bluish shading in Brazil because death rates by and large went down, but they went up, the reddish, in the US. That's another way of looking at the graph I had just shown you. Okay, what about cancer? Cancer death rates went down in both countries. Okay, more so, darker blue in Brazil than in the US, but they went down in both countries. It's one of the only causes that went down according to US data. Even their updated data that just came out say pretty much that same story, except for, I think, lower respiratory infections. All other causes on aggregate had gone up. Okay, so this could be harvesting. People with weak immune systems died from COVID, and when you look at the change in cancer death rates between 2019 and 2020, it looks like it goes down. I had given a talk where there was a cancer specialist there and argued that the US has made tremendous progress in many ways against cancers, which is true for sure, but not in 1 year. And especially this year of 2020, this isn't just progress against cancer. Diabetes rates went up in both countries. Not so surprising, diabetes is a disease that requires constant management. A lot of that was just, set aflame during 2020. Much more sporadic care, checking, maintenance, etc. What's surprising to me is this heart and stroke. Death rates went down in Brazil between 2019 and 2020, while they went up in the US. Also true for these other respiratory diseases, which could well be a miscoding issue. I mean, I think if miscoding comes in, that's the disease that's coming in. But for heart and stroke, it's less clear. External causes, again, mostly down in Brazil, a little bit of exception here for males, young males, mostly up in the US. The US, we know a lot of that's overdoses. Unclassified. Again, the unclassified is higher in Brazil, but it only went up by 0.1 or 0.2 percentage points between 2019 and 2020. Okay. So that is insight into what happened to non-COVID causes between pre-pandemic year and the first year of the pandemic. Okay, so what do we learn from that? I'm going to sum up and let you throw your questions at me momentarily. One is that these decrement approaches that not just myself and Teresa have been using, but very commonly used during this pandemic, may not provide a good approximation of the decline in life expectancy, because death rates from non-COVID causes have changed during the pandemic, and they've changed more for some populations than others. What's really surprising to me is it's not clear a priori if these approaches yield an over or an underestimate of the change in life expectancy at birth. And why is it that some causes declined in Brazil, but increased in the US, or declined much more in Brazil than they did in the US, like cancer? Now, what's true is these decrement approaches suffer from miscoding of cause of death, especially, I think, for respiratory diseases. And you have the problem of unclassified cause of death. None of those issues affect the full life table calculation, right? The full life table calculation doesn't care if deaths ended up in totally wrong categories. It's simply telling you what's the difference in life expectancy at birth, paying absolutely zero attention to cause of death. Okay. So a question is, how common was miscoding of cause of death during the pandemic? Was it higher in Brazil than the US? Is that why we're seeing some of the differences? Is it realistic to think that heart disease and stroke could get miscoded as COVID? Or are those declines in those other causes real in Brazil? Okay, and finally, although it is attractive to say, let's use the full life table, wait a while, and not worry about all of these assumptions of independence of cause of death, can we assume that all excess deaths are actually due to COVID? And what about when this excess, as in Brazil, is actually a deficit? That's all, folks. Thank you. Thank you for inviting me, and thank you for being patient listeners. And
thank you.
I'll stop sharing, yes, so we can do questions.
That's great. Thank you, Noreen. That was fascinating, and I'm sure we have a lot of questions to come. Why don't we start out, I guess what we've been doing recently is having people put in the chat, I have a question, so I get the order right. So if you have a question, if you could just put that, just say in the chat, I have a question, and we'll make sure that you get called on. Give people a moment to clarify their thoughts. Okay, Patrick.
Yes, I said I have a question. It's more a comment, I think, on the puzzle that you raised about the difference in life expectancy and the difference in the standardized death rate between the Latino and Native American population. I think one is a difference in absolute number of deaths, and the other one is a relative difference. It's a ratio. So I think when you're doing the decrement approach to calculate the change in life table in life expectancy using the Chang ratio. So it's really, what matters is really the ratio of deaths to deaths in the previous year that matters. Mm-hmm. And so if you're starting from a higher number of deaths relative to the population already, that lowers that increases the threshold for having a given change in life expectancy. So if Native American are already starting from a higher death rate, it will reduce the impact on the life table, on life expectancy related to other groups. Is that?
Yes, I agree with that. That's great insight.
Other questions? Ian.
Sure. Nice to see you, Noreen. So I was thinking about that scatter plot you had, where on the x-axis you had the proportion of Native Americans living on reservations, and on the y-axis, COVID-19 mortality among that population. And it was like a really striking, strong correlation. And I was thinking about how like South Dakota was up in the one corner and like California was in the other corner. And I just wondered how much you think of this as being related to the proportion living on a reservation versus like other things about those states, where like South Dakota as a state didn't take COVID that seriously, whereas California did. And I kind of thought the proportion, I don't know, it just seems like there's a lot of differences across the states. And I wondered what else you thought about that.
Yeah, so that's a great question. Nice to see you, Ian. So we actually looked at other variables like the openness during the pandemic, which was also reasonably highly correlated with this measure. So what I didn't show you is that we had data on residents on homelands, okay, which are not quite reservations. They include statistical areas beyond actual reservations. And so we could compare characteristics. We couldn't get COVID on homelands versus COVID not on homelands, but we could get the covariates from the ACS or the BRFSS on homelands versus not on homelands. And they were almost uniformly worse in the sense of higher poverty, more crowded living conditions on these homelands, which makes me think that, you know, there is these characteristics are truly, these risk factors are truly worse on reservations than not on reservations, right? These are all characteristics of the Native American population compared to COVID of the Native American population, right? But I agree. I mean, it's an aggregate analysis, right? There's probably lots of factors going on, but I have good reason to believe that poverty is higher, infrastructure is worse, disease rates are worse on homelands than not homelands, and hence on reservations, which are pretty highly correlated with homelands.
Before I get to the next question, I just want to remind the graduate students in the room who are planning to attend the pro seminar that runs from 1:30 to 2 o'clock to stay on this link after we end, and it'll begin at 1:30. Okay, next question, Adriana.
Hi, Noreen. I wanted to kind of go back to the Hispanic versus other groups comparisons. And, you know, you highlighted some differences between them and whites in particular. But I was kind of surprised at seeing how much worse they fared than Blacks. Ex ante, I guess that wouldn't have been my expectation. And you listed a lot of risk factors that are also quite prevalent among Blacks, like, you know, obesity, diabetes, things like that. So, but I think you gave some clues, but I just wonder if you want to kind of add anything to it. So if I understood correctly, your tables did show that they were more likely to be in high risk occupations with relative to Blacks. Is that right? And so I think you gave two clues there about the difference. One was that you said that Hispanic populations tended to have the highest rates of overcrowding or living arrangements with multiple families. Mm-hmm. And the other one had to do with the types of jobs that they did, that maybe they were more likely to be exposed. And so my question kind of was, am I understanding that correctly? And do you think there are other factors? Because I kind of found that comparison somewhat unexpected, that the kind of, my ex ante ranking would have been that Blacks would have fared the worst, I suppose. I don't know.
So great question. Thanks. Great to see you. So I'd say there are a few more factors, one of which is language issues, right? So getting information about how to protect yourself, how the disease is spread is more complicated for a population, a high proportion of which doesn't speak English. And I'd also say the possession of health insurance is far lower among the Latino than the Black population, and the undocumented population, which would have been very resistant potentially to seeking healthcare or to receiving any of the financial benefits during the pandemic. But what I want to clarify, I agree with you that those numbers look a little contrary to expectation, is that when you eventually get the full life tables, which NCHS had way before we had, the total loss for Blacks was virtually the same as for Latinos. The change in life expectancy between 2019 and 2020, I have no idea of 21, and we won't know for a while in 21, because the death rates from non-COVID causes went up much more in the Black population. So something like 90% of quote excess mortality for Latinos was COVID. That number was more, I'm not sure I'm remembering correctly, on the order of maybe 70% for Blacks. So a lot of those comorbidities, which are, except for obesity and diabetes, much higher in the Black population than the Latino population, were probably related to that higher excess deaths among the Black. So that's as I said, the multiple decrement approach in terms of it coming close to the actual total change in life expectancy did worse for the Black population than the Latino. Does that help answer the question?
Yes, partially, yes, thank you.
Okay. I have two more questions in direct messages to me, first from Ann Pebley and then from Haram. So Ann?
I just wanted to ask Noreen and sort of fill in the response to Adriana. So I also remember that on our tables that looked at frontline workers, and particularly sort of public-facing frontline workers, Latinos were much more likely to have those kinds of jobs, or somewhat more likely to have those kinds of jobs than Black workers. That's right, huh, Noreen? I mean, I don't have the tables in front of me, but
certainly not from our data, but we certainly know in terms of informal jobs that would have had absolutely zero protection. That would have been much more common among Latinos. But I think they had the highest proportion of any group of frontline workers. The males did.
Right.
Yeah.
I thought even in the ONET data that was visible, but I've forgotten. So the other thing is absolutely. I mean, there are other studies, and I can't cite them right now, but that have looked at extended family households. And I really think, at least in some areas of the country, I would certainly say it's true in Southern California, that extended family households play a huge role, particularly for immigrants of all ethnicities and national origins, or most of them, but perhaps especially for the Latino population. So I think that really should be emphasized as well.
Mm-hmm. And in fact, it's high for Native Americans, but even higher for Latinos than Native Americans, the multi-generational households. Mm-hmm.
Thank you, Haram.
Yes. Hi, Noreen.
Hi there.
Good to see you. So, quick question. You briefly mentioned something along the lines of the death misclassification, particularly with COVID deaths. So I wonder if you have any more insights, in particular in Brazil, because you seem to have data by state. So as you mentioned, some of the states that were heavily affected were in the north, in particular very poor states like Amazonas and Pará in the north. So the misclassification would be perhaps quite relevant, I don't know, or how large that might be in those states. And the second issue is deaths.
Well, could you say that first, what the question was with regard
the misclassification of deaths?
Oh, the misclassification.
Right. The traditional way we've done it, at least in the past, in mortality analysis, just sort of correlate, the potential causes who might be misclassified into other ones and see how large the correlation might be with these other causes, like, the indirect way of trying to extract the causes that could potentially be misclassified into closely somewhat related, like respiratory conditions, which early on, a lot of these deaths were assigned to that classification. And the second issue is deaths undercounts, which is very common even before the pandemic. It was quite common in Brazil to have a fairly large death undercount for the population in general. But in particular, again, going back to the issue of these poor states in which a lot of these deaths could have been gone unregistered, particularly again in the Amazonan area and the Pará area that were fairly isolated, had a high hit early on in the pandemic. And just those two issues, I don't know if you have any insights.
Okay, thank you. So when you talk about undercount, you mean undercount of deaths rather than population? Yeah.
Exactly.
Yeah, so I'm not a good one to answer that. I'd have to have my Brazilian colleagues on who aren't there. I mean, I think they would agree with the fact that misclassification of cause of death likely varies and is going to be worse in the North than the South. They felt pretty strongly that the total death reporting data that they got directly from the relevant ministries was pretty complete, and it changed almost not at all from when we wrote the paper till a half a year later. So it's not delayed reporting, right? Now you can say maybe it'll never be reported or it'll be reported a year or two later. That I can't answer. You know, I'm sure there has to be misclassification. I mean, it's hard for me to imagine, especially prior to the ability to test the virus. And that was true for many months early in the pandemic, where there were no tests available to see if it was COVID or flu or something else. And that also would have been somewhat differential across hospitals, although they would argue that hospitals suffered dramatically across the entire country in that early period. Yeah, so, you know, the disparities in what you're saying may be even greater than what we're measuring, right? How that accounts for the more technical problem of multiple decrements, overestimating that, I can't get my head around.
Thank you. I have Anne had another question.
Yeah, I just wonder if you guys ever looked at sort of, maybe you don't have this, but by state in Brazil, because, you know, you might expect some of the underreporting or misclassification during the pandemic to have varied depending on the politics of the people in government. And I wonder, you know, because they had lots of incentive to underreport COVID cases as opposed to other respiratory diseases. And so I just wonder whether, you know, anybody's taken a look at that in Brazil. You may not know this, but.
So we did, you know, all of our work is by state, and in an early draft, not one that was published, we did look at the party affiliation of governors. But, you know, that's hard to reach a conclusion because the death rate could be truly higher or could be even higher than what we see because of underreporting, right? There's no metric or yardstick for what the true level should have been.
True.
Yeah,
that's true. But I just think that's going to be a very interesting and troubling topic for the future, trying to sort out what kinds of politically associated underreporting has occurred in lots of places.
Yeah.
We're trying to deny COVID.
Right. And it could be that, you know, denying COVID is what has led to an overestimate of non-COVID causes, since you can't deny the death altogether. But what would that come out as? Do you think it'd come out as pneumonia or some lower respiratory disease, not heart disease or stroke? So, yeah.
Yeah, it depends on the speed with which somebody dies, maybe.
Maybe. And how many comorbidities. So what we do have, and we have not looked at, and we've talked about maybe looking at, I don't know where to begin, is that we have data on all the underlying causes on the death certificate, right? And you could start to look at that whole mass of stuff and try to make sense out of it.
I'm always very skeptical about the quality of that information. Yeah, certainly I am in the US quite skeptical.
Yeah,
about the quality
I am too, but it's the closest you can come to the potential type of miscoding that's going on between causes.
I think it would be interesting if you have the when the death was registered, because the early the death was registered, perhaps the more likely it is misclassified, because it is when people in rural areas in particular had no knowledge of how to classify these deaths, are more likely they're undercounted or misclassify them, as opposed as getting closer more into the present. It was perhaps a more common practice to identify that the symptoms that the deceased could have had that could be more related to COVID. So again, going back to the rural areas that are fairly isolated, that they don't tend to have medical examiners who actually provide these causes of death.
So are you saying when it was registered relative to when it occurred? Because clearly the pandemic took a very different toll throughout 2020.
Right, because I don't know how those death certificates are collected. In Mexico, for instance, they identify when the death occurred. But in other places, they do not identify when the death occurred, but then when it was registered.
Mm-hmm. Yeah. So yeah, we can see whether we can get that data. I don't know, Teresa, did you want to say anything or correct anything that I said that was completely or partially incorrect?
No, like you said, I'm also not the person to talk about the data quality in Brazil.
Yeah, I meant in general, not just the Brazil questions. No.
Do we have any other questions? Okay, well, if not, let me thank Noreen so much. That was a really wonderful talk, lots to chew on, lots to think about, so thank you. And a reminder for folks who are staying around for the pro seminar, please stay on this link. It'll begin at 1:30. And a reminder that next week we have Elizabeth Wrigley-Field coming from University of Minnesota. So thank you, everyone. Thank you, Noreen, and have a great rest of your afternoons. Bye, everyone.
So I get a 4-minute break.
You do, you get a 4-minute break. And thank you. I wish we had lunch for you.